Hello everybody. Welcome to PGOG postgraduate class in obstetrics and gynecology for postgraduates as well as for consultants. Today's topic is placental abruption. Definition of antepartum hemorrhage is whenever there is a bleeding from or into the genital tract which is occurring after 24 weeks of pregnancy but before delivery of the baby or before completion of second stage of labor. This is a must-know definition for postgraduates as well as for undergraduates of obs and gynecology. Definition of placental abruption is it is a type of APH. That means there is a bleeding from or into the genital tract from 24 weeks up to the before delivery of the baby. And this bleeding is because of the premature separation of normally implanted or normally situated placenta. There can be a partial or complete separation of the placenta. Now, why antepartum hemorrhage leads to maternal mortality? For that, what we need to remember is more than 600 ml per minute. That much of the blood is flowing through the intervillous space at term. So whether it is the bleeding because of the separation by abruption or placenta previa, whenever the placental cause is there, the amount of blood which is getting lost is so high that if it is 600 ml per minute is the blood flowing through the intervillous space, we can imagine how much will be the collection of blood over hours. What are the complications of placental abruption? Maternal complications are mainly hypovolemic shock, DIC, and acute kidney failure, fetal distress and intrauterine death, and neonatal are prematurity, asphyxia, and low birth weight babies. Now, as a rule, we say that abruption affects fetus as well as mother, whereas placenta previa mostly affects mother. So why fetus is affected in abruption is placenta acts as a fetal lung. Fetal lungs by providing oxygen, fetal digestive system by providing nutrients and removing the waste, fetal kidneys by removing the waste. So whenever there is a placental separation, all these functions of the placenta are getting hampered, and that is the reason why fetal affection is seen in early stages, even in early stages of placental abruption. According to the severity of blood loss, how we can divide the antepartum hemorrhages. Spotting is when there is only a minimal bleeding. Minor hemorrhages when amount of the blood loss is less than 50 ml and there is no further bleeding. Bleeding has stopped or bleeding has settled. Major hemorrhages when the blood loss is in the range of 50 to 1000 ml, but there are no signs of clinical shock. Massive hemorrhages whenever there is a blood loss is exceeding 1000 ml and or there are features or signs of clinical shock. Clinical classification of abruption has been given in some textbooks and it is stage 0 whenever it is a retrospective diagnosis that after the delivery we examine the placenta and we find the presence of a depression with the presence of a retroplacental hematoma. Stage 1 is mild when there are no adverse effects on mother or baby and there is usually the bleeding is slight. Stage 2 is when it is moderate stage when there are maternal changes in blood pressure and pulse are there as well as there is a fetal distress. So fetal distress indicates stage 2. Whereas if there is intrauterine death, it indicates stage 3 or severe. Apart from intrauterine death, there will be maternal serious complications such as maternal shock, DIC or acute kidney failure. What is the etiopathogenesis? For that, we need to again go back to basics. Deciduea is nothing but the endometrium of the pregnant uterus, and we divide the decidua in 3 parts. Wherever the placenta is getting implanted, it is decidua basalis, this yellow part. Deciduea parietalis is the part of the deciduea which is present at the over the inner lining of the uterus, that is blue one. And deciduea capsularis is the one which is the part which is covering the growing conceptus, and by the end of first trimester there is a fusion of this Decidua parietalis with the Decidua capsularis. Spiral arteries are supplying the Decidua. As here we can see the uterine arteries giving the branches such as arcuate arteries, radial arteries, apical arteries, and from these the spiral arteries are penetrating the endometrium, and in pregnancy Decidua is being supplied by the vascular blood supply of the Decidua is spiral arteries. So how placental abruption starts is there is a rupture of spiral artery in Decidua basalis. This is the Decidua basalis, and here there is a rupture of spiral artery. This hematoma splits Decidua basalis so that a thin layer of Decidua basalis remains attached to the myometrium, whereas the outer one is pushing and compressing and lifting the adjacent placenta away. So this is a hematoma where on one part is a thin layer of Decidua basalis still adherent to the myometrium. Whenever there is a preeclampsia with placental abruption, spiral artery, there is a incomplete invasion by extravenous trophoblast in patients of preeclampsia. There is improper remodeling of spiral arteries, and there is atherosis of spiral arteries. Atherosis is there is a damage to the vessel wall in cases of preeclampsia that makes the spiral arteries more prone for rupture, and that is why there is a strong association of hypertension in pregnancy and placental abruption. Types of placental abruption, we can say spontaneous or non-traumatic and traumatic. Traumatic can be either a motor vehicle accident or any accident, or even a trauma because of domestic violence or any other violence. Revealed, concealed and mixed. Revealed is where there is no retroplacental hematoma formation. There is a marginal separation, and the bleeding is whatever is bleeding is there because of the separation is getting expelled out of the introitus. Concealed is where the blood is getting accumulated behind the placenta and it is not getting out of the cervix. It is completely getting collected inside the uterine cavity, then it is concealed. When there is a mixture of these two, then we say it is a mixed variety, and the presentation will depend on which component is dominant, whether revealed component is dominant or concealed component is dominant. Third way of classifying is non-severe and severe. Severe where there are maternal, fetal or neonatal complications. Now, is the blood in retroplacental hematoma of whether it is of maternal or fetal origin? In non-traumatic abruption, it is always the maternal blood which is contributing to the formation of this retroplacental hematoma. Chorionic villi remain intact. There is a rupture of spiral artery. This is the spiral artery which has ruptured. That leads to the blood being collected in Decidua basalis, pushing the chorionic villi away. Fetal blood is seen in only around 5% of the cases, and even if there is a fetal blood, the fetal blood loss is less. It is only up to 10 ml. But in traumatic abruption, fetal blood vessels are also injured so that the blood in the hematoma, retroplacental hematoma, has maternal as well as fetal component. And usually it is associated with a severe blood loss in the baby. Chronic abruption is whenever there is a placental abruption which is not followed by delivery. In these cases, there is a marginal or minimal placental separation and the bleeding stops. There is a possibility of fetal aneuploidy in these cases. The risk is increases of fetal aneuploidy or chromosomal abnormalities, and it presents as a seen whenever the patient has first or second trimester bleeding. So early pregnancy bleeding, and then the bleeding stops and it continues as a case of chronic abruption. In the predisposing aging factors, there is a long list, but the most important is previous history of abruption in the previous pregnancy, where the recurrences is 4 to 12 with once there is a abruption. Twice it is there, the recurrence rate increases to 25%. Advancing age and parity is a risk factor. Hypertension in pregnancy is seen in 50% cases of abruption. Subchorionic hematoma leading to early pregnancy bleeding is a risk factor. Multiple pregnancy, hydramnios, where there is a possibility of overstretching of the uterus and sudden decompression with the rupture of the membranes, or delivery of one of the baby in multiple pregnancy, that leads to the development of abruption. With preterm pre-labor rupture of membranes also, if there is sudden decompression, it is associated with development of placental abruption. Cigarette smoking, cocaine use is a risk factor, and single umbilical artery is also a risk factor for placental abruption. Other risk factors are subclinical hypothyroidism, raised antithyroid antibodies. Maternal thrombophilia is the one emerging, which is being studied quite extensively as a risk factor for abruption. Short umbilical cord, trauma in the form of accidents or domestic violence. Now there are studies which are going on to search whether for the predictors of abruption. So alpha fetoprotein, maternal serum alpha fetoprotein more than 280 microgram per liter in the third trimester is a some studies are showing it to be a possible predictor of abruption. Similarly, raised PAPPA, pregnancy-associated plasma protein A, and inhibin are also under study as predictors of abruption. But unfortunately, in spite of this long list of risk factors, in 70% of the cases, abruption occurs in low-risk pregnancies. Can we prevent placental abruption? Magnesium sulfate, whenever it is given in severe hypertension in pregnancy, as was done in MAGPIE trial 2002, the result showed that there was reduction even in the risk of abruption, and that is how magnesium sulfate, if given in severe hypertension in pregnancy cases, prevents abruption. Aspirin with a dose of 100 mg per day also has a probable role in preventing placental abruption. Folic acid supplementation has been tried in many studies, but it has not been proven by randomized control trials that it definitely leads to the prevention of placental abruption. Emerging research shows that antithrombin treatment, such as low molecular weight heparin, has a possible role, especially in patients who have a previous history of abruption in the previous pregnancies. How to manage a patient with history of previous abruption? Now, whatever test of antenatal fetal well-being we do, these are not predictive whether the patient will have a repeat abruption or not. That is the reason induction is usually indicated by 37 to 38 weeks whenever there is a previous history of abruption. Risk of repeat abruption is high. What is a classic presentation of placental abruption? Pain in abdomen which is sudden in onset, bleeding PV and uterine tenderness. This is a classic presentation, but many a times we don't get this classic presentation, and patient might present with other findings such as backache, non-reassuring fetal status, persistent uterine hypertonus on examination, and presence of uterine contractions. Now, there is a diagnostic difficulty whenever it is a mild abruption. Whenever it is a concealed variety, it leads to diagnostic difficulty and leads to usually late diagnosis, and that is why concealed variety has got the worst prognosis as compared to revealed or mixed variety. And whenever it is a posteriorly placed placenta, that also leads to the diagnostic difficulty because tenderness over uterus will not be observed in these cases. Whenever there is a shock which is disproportionate to the amount of visible blood loss, then we should consider it as a clue for the diagnosis of abruption. Whenever it is a case of abruption with intrauterine death, it carries a bad prognosis because it indicates that already mother has lost 50% of the total blood volume. By the time intrauterine death takes place, so much of blood loss is already there. That means it is around 2.5 to 3 liter blood loss is already there, either in the form of concealed, mixed, or revealed variety. There is a risk of patient going in hypovolemic shock, which might initially will be reversible, but which might become irreversible if remains untreated, and consumptive coagulopathy risk is also very high. Most common, if you are asked what is the most common cause of consumptive coagulopathy in obstetrics, which is clinically profound, your answer should be placental abruption. Abruption is always associated with intravascular coagulation, and to maintain the patency of microvasculature, fibrin clot lysis takes place by activation of plasminogen getting converted to plasmin. Fibrinogen level falls to less than 150 milligram per dl because of the formation of these multiple small fibrin clots in the microvasculature all over the body. It is associated with severe thrombocytopenia because clots also have platelets as a component, and multiple coagulation factor deficiency also sets in. This is how there is an occurrence of consumptive coagulopathy. That intravascular coagulation is consuming the coagulation factors, consuming the platelets. And why we call it as a disseminated? Because it is widespread all over the body. Dilutional coagulopathy adds to consumptive coagulopathy. Now, whenever we treat the patient, sometimes we give only packed red cells and not giving fresh frozen plasma as a supplement for coagulation factors or platelets for thrombocytopenia. If only RBCs are replaced or only crystalloids are given, it leads to the dilutional coagulopathy. So consumptive coagulopathy worsens because of the mismanagement, and it leads to the addition of dilutional coagulopathy. With concealed variety, there is higher risk of DIC. So high disseminated intravascular coagulation is more common with concealed variety. What is happening with concealed abruption is there is a raised intrauterine pressure as blood is getting collected inside the uterine cavity, and there is no escape of the blood through the cervix outside. So what it leads to is a raised intrauterine pressure. That leads to the more release of thromboplastin in the spiral veins of the placental site, and that is a trigger for consumptive coagulopathy. There is excessive release of thromboplastin. So what is thromboplastin? Thromboplastin is basically it is an enzyme which is secreted by platelets. Now in these patients of retroplacental hematoma formation and abruption, placental or decidual thromboplastin enters into the maternal circulation. It initiates coagulation by conversion of prothrombin to thrombin. This thromboplastin initiates coagulation. So ultimately disseminated intravascular coagulation sets in, DIC sets in. Body tries to maintain patency by clot lysis, which leads to the rise in FDPs, that is fibrinogen degradation products, and D-dimers. Meaning of the word disseminated is widespread. So there is a widespread intravascular coagulation, and that is the main reason of this is release of thromboplastin by the platelets which are present in the retroplacental hematoma. What are the risk factors for DIC in abruption? Intrauterine death, concealed variety, mixed variety with dominant concealed element. These are the cases where there is a high risk of patient going in DIC. Now, what is covalent uterus? Other name of covalent uterus is uteroplacental apoplexy, where there is a blood which is getting accumulated into the myometrial layer. So, blood is getting accumulated in the myometrial layer, and it is more commonly seen with concealed variety or with a mixed variety where concealed component is dominant. That blood retroplacental hematoma, but there is a continued collection of the blood with a further separation of placenta. and there is no outside way for the blood to go out. So where the blood goes is towards the myometrium. It leads to the blackish bluish discoloration over the serosal surface of the uterus, and blood seeps even into the peritoneal cavity. It is seen around the tubal serosa. In the leaves of broad ligament, there is collection of blood. Even around the ovaries also blood gets collected. Now, covalent uterus, because the myometrium is getting infiltrated, myometrial fibers are getting interspersed with the blood, there is a defective myometrial contractility, and that is why covalent uterus is a risk factor for atonic postpartum hemorrhage. But it is not the sole indication of hysterectomy. If the PPH is not responding to uterotonics, then only one should proceed with a decision to do the hysterectomy for covalent uterus with atonic PPH. First, we have to try the uterotonics. Acute kidney failure is another serious complication of abruption. It is common whenever there is an abruption in patients of preeclampsia. It is usually because of the incomplete treatment of hypovolemic shock. So if the hypovolemic shock is not aggressively treated or completely treated, that leads to the development of acute renal failure, acute kidney failure. This acute kidney failure is usually reversible and rarely it needs dialysis. What is the differential diagnosis of abruption? Placental abruption, processus placenta previa. So if we do ultrasonography for postgraduates, what you must remember is, unfortunately, ultrasonography has low sensitivity to diagnose the placental abruption. Ultrasonography plays a major role in diagnosis of placenta previa, but it is not an important or helpful investigation in patients with abruption because ultrasonography has low sensitivity and there is a high rate of false negatives. That means even if there is an abruption, report might come as normal. Small separation, if there is a small placental separation, it is missed by ultrasonography because here the retroplacental hematoma and the placenta have same features on ultrasonography. So ultrasonographically, you cannot differentiate between a normal placental tissue and a blood clot. Fresh blood clots and placenta, they look same on ultrasonography. False positives also can be there for abruption, such as some false positives are, even if there is no abruption, sometimes it can be labeled as a case of abruption, though it is a case of placenta previa. Now, if there is a fresh blood which trickles up to the cervix, and there is a formation of blood clots here, and these blood clots look exactly similar as placenta, and then in that case, this case can be misdiagnosed as a case of placenta previa. So again, it will be a misdiagnosis and it will be a false negative for placental abruption. MRI is better to differentiate between placental blood clots and placenta as compared to ultrasonography. Raised D-dimer, whenever D-dimers are raised, it is suggestive of abruption, but it is also not a very useful marker in early or mild cases of abruption. Painful, now usually we say at undergraduate level that whenever the bleeding PV is painful, it is abruptio placentae or placental abruption, and whenever it is a painless bleeding, classically we teach that it is placenta previa. But as a postgraduate, what you should know that there can be a painful bleeding in placenta previa if patient goes in labor. So all cases of placenta previa will not be having painless bleeding. Some patients might be having pain in abdomen because patient has already gone in labor. If it is a posterior placental abruption, posteriorly placed placenta, then in these cases there can be painless bleeding and there might not be any tenderness over the uterus. Mild abruption is always there is a difficulty in diagnosis. Other DDs are vasa previa, where the bleeding starts typically with the rupture of membranes. Cervical cancer, on per spectrum examination, we can differentiate between the uh, other causes of APH and cervical cancer. And there is a category which is called as unexplained antepartum hemorrhage, where the exact cause is not known even after the delivery of the patient. Continuous pain in abdomen suggests abruption, and intermittent pain in abdomen is favors that patient is in labor. That is another differentiating point between the whether the patient is in labor or she has got a placental abruption. So remember, placental abruption is a clinical diagnosis, and ultrasonography is of less use in the diagnosis of placental abruption. Coming to management, we have to see the vitals, pulse, BP, urine output, oxygen saturation. Or abdominal examination might show tenderness, and woody uterus or stony hard uterus might be there, which is seen usually in the late stages of placental abruption. Or speculum examination might give us an idea about how much is the cervical dilatation, and also it will help us to rule out cervical lesions as a cause of antepartum hemorrhage. Vaginal examination to be done after excluding placenta previa by ultrasonography. In the management, usually if the fetus is alive, we proceed with the cesarean section in placental abruption, because further trial of labor might lead to the sudden IUD with further separation of the placenta. If fetus is dead, then one should go for vaginal delivery with aggressive replacement of RBCs, FFPs, platelets, and crystalloids. So, aggressive treatment of hypovolemic shock, and along with hemorrhagic shock, and along with that vaginal delivery. That will be the correct management if fetus is dead. How much RBCs, FFPs, platelets are to be given is guided by CBC platelet count, fibrinogen level, prothrombin time, and partial thermoplastin time. Blood products are to be given, blood components are to be given, and crystalloids are to be infused in sufficient quantity. But only crystalloids, hyperperfusion or excessive administration of only crystalloids or only RBCs will lead to the dilutional coagulopathy, which needs to be avoided. Single dose of corticosteroids is indicated whenever the pregnancy is between 24 to 34 weeks of the pregnancy with a preterm abruption. Anti-T should always be given antenatally whenever a patient presents with placental abruption, because possibility of feto-maternal leak and feto-maternal hemorrhage is very high in patients of abruption of placenta. Cohort test should be done in the postpartum period to decide the dose of anti-D in patients with placental abruption. In spite of giving antepartum, we need to give the postpartum also, depending on the result of Cohort-Betke test. Decision delivery interval is very important whenever we take a decision for caesarean section in patients with placental abruption. It should be less than or equal to 20 minutes to have a best outcome in patients, especially whenever there is a fetal distress with placental abruption, fetal bradycardia with placental abruption, other features of fetal distress, then decision delivery interval should be as less as possible, and we should be conducting the drills in the obstetric units at our setup, each individual setup, so that everybody from attendant, nurses, to anesthetists, obstetricians, everybody has a goal that there should be a decision delivery interval should be shortened, and ideally it should be less than or equal to 20 minutes. What is the place of artificial rupture of membranes in abruption? It might compress the spiral artery, ruptured spiral artery, and it might reduce the bleeding. Is the postulation to recommend the artificial rupture of membranes, which is ARM is recommended since many decades as in the treatment of abruption. It might reduce thromboplastin release, and it might reduce the development of DICs, another thought to be the advantage. But these advantages are not proven by evidence. ARM accelerates labor, that is the advantage. But remember that whenever it is a preterm abruption and suppose there is an intrauterine death and you want to give a trial of vaginal delivery in these patients, this bag of membrane acts as a good cervical dilator. So we have to weigh the advantages against the disadvantages of doing ARM in patients with abruption. It is advocated thinking that it will lead to reduction in the bleeding and reduction in the development of DIC, but there is no proven evidence for this postulate. Now, how long we can wait for the vaginal delivery in patients of abruption? When we were doing post-graduation, we were said that patient needs to deliver within a stipulated time of say 6 hours or 8 hours. But no such time limit is recommended in modern obstetrics. And what needs to be stressed is there should be aggressive treatment of hemorrhagic shock. So if hemorrhagic shock is treated aggressively, then there is no need to proceed with caesarean section just because patient has not delivered at the end of say 6 hours or 8 hours. Aggressive blood products and crystalloids are more important than keeping the time limit for the duration of the labor. Third stage arrest of bleeding is usually by uterotonics and uterine massage in the majority. And though there is a defect, sometimes there is a defective coagulation. Coagulation plays a minor role in the arrest of bleeding in third stage. And in these cases, what is more important is to go ahead with the active management of third stage of labor. Hysterectomy is rarely required for the postpartum hemorrhage in these patients. But because APH is a risk factor for PPH, we need to proceed with active management of third stage of labor. We have to use the uterotonics and we have to proceed with uterine massage. These are the patients where usually multiple blood transfusions are required. Patient if there is a massive hemorrhage, patient goes through shock also. And there is a hypovolemic shock. There is, in these cases, multiple transfusions are given, and that adds to the risk of thromboembolism in the post-delivery period. And that is why placental abruption is an indication for thromboprophylaxis in postpartum period is important point in the management. Postgraduate students and consultants should remember that once patient comes out of DIC, we have to proceed with the thromboprophylaxis and especially non-pharmacological thromboprophylaxis such as use of stockings needs an early ambulation. Breathing exercises are to be followed more meticulously in patients with placental abruption. Whether we have to give whole blood or PRCs, that is another question. If whole blood is given, there is increased risk of pulmonary edema. Whenever PRCs are given, it is seen that there is increased risk of acute kidney failure. So there is a risk with both. But presently, what is the current recommendation is blood components are being used in massive hemorrhage. Whenever there is a massive hemorrhage, what we initiate is called as a massive transfusion protocol. So each setup or each obstetric unit should have their own massive transfusion protocol where the blood bank is sensitive. If you say I need massive transfusion to initiate massive transfusion protocol, in other words, you don't have to order separately. That itself indicates that you need 6 PRCs, 4 FFPs, and 4 platelets. So this is the usual effective proportion rather than 4 is to 4 is to 4. If it is used as 6 is to 4 is to 4, the end result is said to be better. Cryoprecipitate is to be given whenever the serum fibrinogen level is less than 100 mg per dl and 10 units of cryoprecipitates are required to correct the hypofibrinogenemia. Now, there is a limited place of expected management in abruption. What do you mean by expected management is you allow the pregnancy to proceed. That is expected management in placental abruption. You don't terminate the pregnancy. So there are selected cases of preterm chronic abruption where we can give expected management. Continuous fetal monitoring is mandatory, but in spite of that, unpredictable further placental secretion can occur anytime and always there is a risk of intrauterine death. So we have to weigh the risk of perinatal mortality because of the prematurity against this sudden IUD and accordingly take a decision, and that is why it has an expected management has a limited place in the management of placental abruption. Should we be using tocolytics in abruption? There is no improvement in the outcome in preterm abruption with the use of tocolytics. Magnesium sulfate use also does not improve the outcome in patients with placental abruption, and that is the reason tocolytics are not recommended in preterm abruption. Thank you so much. Especially at the end of today's lecture, I want to thank all the subscribers for a encouraging response. My only request is please suggest topics so that I can now, whatever I have uploaded till now is, I know that it is just a drop in the vast ocean of obstetrics and gynecology. I have contributed to a very small extent till date. But to prioritize which topic to be handled first, which topics you need uh, urgently. For that, my request to the postgraduates as well as to the consultants is to suggest the topics so that I will take those topics first and then proceed with the remaining classes of obstetrics and gynecology. Thank you once again for the encouraging response to this PGOG YouTube channel.